Why do healthy lungs stay open? Why do emphysema patients develop hyperinflated lungs? Why are ARDS lungs so difficult to ventilate? The answer lies in understanding the mechanical properties of the lung and chest wall. Every breath is the result of a continuous battle between forces trying to collapse the lungs and forces trying to expand them. Today we will explore compliance, elastic recoil, tension, surface tension, and the interaction between the lungs and chest wall, concepts that form the foundation of mechanical ventilation. The respiratory system is composed of two major mechanical structures, the lungs and chest wall. The lungs naturally want to collapse inward. This tendency is called elastic recoil. The chest wall, on the other hand, naturally tends to spring outward. These opposing forces create a negative intrapleural pressure that keeps the lungs expanded. At the end of a normal exhalation, the inward recoil of the lungs exactly balances the outward recoil of the chest wall. This equilibrium occurs at the functional residual capacity, or FRC. Understanding FRC is important because it is the resting position of the respiratory system. Now, let's discuss compliance. Compliance describes how easily a structure expands when the pressure is applied. Mathematically, C is equal to delta V over delta P. High compliance means a small pressure change produces a large volume change. Low compliance means greater pressure is required to achieve the same expansion. Normal lungs have moderate compliance. Diseased lungs often do not. In pulmonary fibrosis and ARDS, compliance falls dramatically. The lungs become stiff. Patients must generate large pressure changes simply to take a breath. This is why ARDS patients often appear exhausted and require ventilatory support. Now consider emphysema. Destruction of elastic tissue reduces elastic recoil. Compliance increases. These lungs inflate very easily. However, if they don't empty efficiently because the elastic recoil needed for expiration is lost. Air trapping develops, residual volume increases, hyperinflation occurs. This explains the classic barrel chest appearance. The chest wall also has compliance. Opacity, kyphoscoliosis, pregnancy, and abdominal compartment syndrome reduce chest wall compliance. Even if the lungs are normal, breathing becomes more difficult because the thorax cannot expand effectively. In the ICU, reduced chest wall compliance often increases airway pressures despite relatively healthy lungs. Another important force is surface tension. Every alveolus contains a thin fluid lining. Water molecules attract each other and generate surface tension. Surface tension promotes alveolar collapse. Without surfactant, the work of breathing would be enormous. Type 2 pneumocytes produce surfactant, which lowers surface tension and improves compliance. This is why premature infants lacking surfactant develop neonatal respiratory distress syndrome. ARDS decreases compliance. Pulmonary fibrosis decreases compliance. Emphysema increases compliance but decreases elastic recoil. Obesity reduces chest wall compliance. Surfactant deficiency decreases compliance and increases work of breathing. Every ventilator setting you choose is influenced by these mechanical properties. Whenever you see high ventilator pressures, ask yourself, is the problem the lung, the chest wall, or both? Understanding respiratory mechanics transforms ventilator management from memorization into physiology.